All right, everybody, welcome to the MD Roundtable. And tonight I have the extreme pleasure to introduce to you our new Associate Medical Director, Dr. Donald Phillips. Dr. Phillips will be assisting Dr. Frame with some of the many duties that he keeps track of that have just been kind of an overwhelming thing for him trying to do all by himself. And Dr. Phillips is starting tonight with his very first MD Roundtable. Dr. Phillips has been around. He was a paramedic before he was a physician, just like Dr. Frame. He's been an emergency room physician for many years. EMS medical director for, are we there? I'm sorry, I had an internet hiccup. Can you hear me? Sorry, I had an internet hiccup here. We had a power hiccup. He's an EMS medical director, as you heard, now for Shackelford County EMS, for Parker County EMS out of Weatherford. And he's just got accolades. He was on the Governor's EMS and Trauma Advisory Council Medical Directors Committee. He's been around the bus a few times. So that having been said, it looks like we've got a wonderful lecture. Please keep your microphones muted unless you have a question. Then you can unmute your microphone, ask the question, remute it so that your noise will not disturb. If you can't use your microphone, there's a chat box that's available there that you can also use, and we'll try to keep an eye on that. He may check with you to see that you're still here, and then I'll be checking with you at the end to make sure, because you do have to participate to get credit for this. I see Jonathan Vasquez from 400, I believe, Justin Harris, Jason Holliday, Chris Snyder, Mark Schmidt, Deborah Smith, she's a different one, Doc, and Gabriel Gann. So I'm also going to be locking the room after I mute the microphone so nobody else can join in at this time. Have fun, Dr. Phillips, and it's all yours.
Oh, we definitely will. So you've heard a little bit. First off, the new thing in medical education is declaring any conflicts of interest. So in other words, I don't have anything to declare, like a financial interest in some company that makes who's-its to fix these particular types of fractures or anything. You got a real brief biography there. I actually started in the EMS in 1981. And that's obviously a long time before most of y'all were even born. And at that time, I was still in high school and went to an EMT course. And so that occupied my Saturdays and Sundays for a good 5 months. And then I had obviously high school Monday through Friday as well. So it's been an interesting ride over all these years. I graduated medical school in 1991, and I've actually had the opportunity as a result of all that to see EMS in a lot of different settings, because I grew up in the area north of Dallas, so we saw things from that particular side of the Metroplex, and then I went to medical school and undergrad in Fort Worth, got to see those things there, where it was, went from a fire base to a contractor base, and then I went up to Missouri and saw how they did it there for my internship, and then ended up in Columbus, Ohio for my residency. That is a very different system up there. Not bad, it's just different. And it was great education to see the difference between all these different places. I was in the Air Force for 4.5 years. So I've seen military medicine as well. I have been a tactical EMT and helped to set up a SWAT team for St. Charles County Sheriff's Department. That's actually a service that's now known as St. Charles County Police Department, so they've changed a little bit. But I'm still a good friend with the other physician that's on that particular team, and he's actually very well known to EMS because he was the president of the National Association of EMS Physicians a few years ago. So it's nice to come back around to this side of things, to be able to share and to help others to get into this. And so I would encourage you, if after the lectures, if you have questions about anything, let me know. I'm more than happy to sit down and have a conversation with any of you about anything at any time. Okay, well, maybe not any time. 3 in the morning is probably not a good time. But my point is, none of us in this business have gotten where we are without somebody else being willing to share their education, their knowledge with us. So it's incumbent upon us at our stage to share that knowledge with you. So if at some point you have a question or something, I've got the chat box open. So, you know, if you have something that you want me to address, let me know. We're more than happy to do that. So specifically, I was initially asked to talk about the Lefort fractures. So let's talk a little bit about René Lefort. There's that man himself right there. And you'd think that it would have been older as something, you know, where it would have had to have been sketched or painted, but there's actually a photograph of the man because he died in 1951. I thought it was interesting. I just noticed today that he died on his birthday. That's not a good birthday gift. He was a French surgeon. He developed this classification. Now, there's a lot of mythology and stuff that surrounds how he came up with this, but he actually used decapitated and whole cadavers in his experiments to come up with this classification. And he used a variety of injury mechanisms. Some of this involved things such as striking them with cannonballs in the face or throwing the decapitated heads against hard objects. So a lot of different things went into this. There's a few little useless factoids that, you know, when you're sitting around the table at the station and you just want to show how smart you are, you can throw these sort of things out. He is the youngest person in France to ever earn an MD degree. He was 21 years old when he did that. Now, for reference, most physicians in America actually start medical school at 22. So he wasn't even the same age as I was when I graduated from college. His father and his uncle were also physicians, and he was decorated for heroism in World War I. Now, I couldn't find the actual citation or anything, but it sounds like it was not because he was a surgeon, which he was, but for some of his other actions that he took during that time. So the Lefort facial fractures. First off, understand these are usually due to blunt trauma. Certainly penetrating trauma can play a role, but most of the time the classic mechanism is blunt trauma. As we talked about, Dr. Lefort came up with this classification system by inducing trauma into cadavers. One story, and turns out that it was probably truly just a story, was that he dropped cadavers from buildings to see the injury patterns. Now, the other thing that I want you to keep in mind, and this is going to come up over and over and over during this lecture, is facial fractures are not generally what is going to kill somebody quickly, okay? Now, you should understand, and if we had it in an unmuted state where we could chat, and we will in a little bit, one of the things that I want you to understand is that trauma generally kills in what's called a bimodal distribution. So either you die really quickly, like within a matter of an hour or two, or you die 3 weeks down the line. And most of those are actually due to infection. The same can be said for these fractures. These fractures, the mechanism of getting this fracture is what, if you're going to die quickly, that will kill you, or some of the other things that can come up, or they develop infections. But for the purpose of EMS, for the time that we have these people, because we're not going to have them for 3 weeks, at least we better not anyway, but repeated primary assessments. So do your primary assessment, your A, B, C, D, E, then do it again, and then do it again, and then do it again. And I'm sure that you have heard this over and over in other lectures from the time that if you're not an EMT paramedic student, from the time that you were a basic, you have heard over and over, repeat those ABCs. If not, let me be the first to tell you, that is what's going to help more than anything. And while this might be on an exam, I'll just tell you that it's really kind of hard to focus on just the Lefort fracture. So we're going to expand this just a little bit. So the Lefort fractures, this is our Lefort 1 fracture, okay? You see the red line there? That is a fracture line. All of those other black lines on there are where the different bones of the skull come together. So keep in mind where that red fracture line is. So let me move the group chat window so that I can see everything on here. So obviously this is the one that's most common for any of these things. It can be unilateral, it can be bilateral, okay? So it's not a pure mechanism. The most common thing that people with this type of fracture are going to complain about, other than pain, is that they have what's called malocclusion. Now that, if you want to sound really smart when you call and give your report, you say that they have a malocclusion. But the way that you find that out from the patient is you're going to ask, when you bite down, do your teeth line up normal? Do they feel normal? That's the biggest thing. Now, to truly diagnose this, what you have to do is that you have to hold their forehead still, like up against the bed, and you're supposed to reach up and grab their upper teeth with a gloved hand and pull that back and forth, okay? With this particular type of fracture, the nose is going to stay steady, but the teeth are going to come out. Not all the way out, but they will move outwards with that pressure. So let's move on to the Lefort 2. Now you see that the fracture line is in a different location. This has, the description is a pyramidal arrangement. So it looks like a pyramid. So this doesn't happen as often. This is almost always bilateral. And when you do that same manipulation with the hand in the mouth and holding the forehead still, you're going to see the nose and the mouth all move as a unit. Now let's talk about the Lefort type 3. Obviously, not as many of these, but this is called a craniofacial dissociation. Now, if you look on that far left-hand picture, you see that this fracture line goes through the orbit. It also goes through the zygoma. That's this bone that is facing us, that's just above the teeth on that lateral. And when you grab this, everything kind of moves back and forth, okay? I'll be honest with you, I don't see these very often. I probably have seen maybe 5 in doing this 25 years since my residency. They just don't happen that often. Now, the bad part about this particular one is if you see where the fracture line is, they usually will have leakage of their cerebrospinal fluid. That's what CSF is. And so they have a really high incidence of developing further infections and complications as a result of that. So, once again, it's nice to be able to classify these things. They're high frequency, but they are mixed, okay? So in other words, you may have somebody that has a type 1 Lefort fracture on one side, but then it extends up into a Lefort 3 on the other side. So, you know, the problem is that our patients don't read the textbooks so that they know how they're supposed to be injured. Okay, that's actually a little bit of humor, but the whole point of that is that these things are not pure injuries. So they're usually mixed when they happen. And in this case, these are usually due to high force blunt trauma. Okay, so think about a motor vehicle collision where they smack their face on the steering wheel, or they're playing hockey and they don't have a face mask on and they take a puck to the face, or a baseball. So all of those things can cause this. So it's a high energy, but it's blunt force right in the face. So you really got to think that there may be another injury somewhere. You really got to look for those sort of things, because unfortunately, since I didn't read the textbooks to know how they're supposed to be injured, they also don't always tell you about the other injuries that they've got. So you've got to look for other things. This is why we tell you to go back and do your primary survey over and over and over. And just the same as that E in your trauma assessment is exposure, it also can stand for everything else. That means that you have to look from the top of their head to the bottom of their feet. So please remember that. Now I'm just going to briefly right now ask, do y'all have any questions or anything? Feel free to pop anything in on chat right now. So Justin says, how important is it to differentiate between the types of LaForte fractures in the pre-hospital environment? It's an excellent question. The answer truly is, it's not. Because once they get to the hospital, there will be a CT scan that will be performed, and that's going to really define these things. And, you know, once again, they're usually mixed. And so Gabe says, have we seen less of these since the introductions of airbags and steering wheels? You know, actually, yes. And it's not just the airbags. I came back to Texas in 2003, 2004, December of 2003, so really call it 2004. And at that time, at the county hospital here, we saw a lot of accidents that were brought to the trauma center because of mechanism of injury. And I can't tell you how many times I'd hear about rollover accident where they were wearing their seatbelt and they did a standing takedown on the patient because, well, they were standing outside going, dang, that looks bad. And they're like, well, do you know where the driver is? Oh, that was me. And they're like, what? So the roll cages that we have in these cars as well are so much better. There's so much impact that's absorbed by that front end before it actually gets to the roll cage that surrounds all the passengers in that car. Another great example, and I've used this in other lectures, is a video from Texas Motor Speedway in 2006 or 2007. During a practice lap, a driver hits a wall at over 200 miles an hour and rolls, I think it was 12 times. And then the next shot shows somebody running up to the car from one of the rescue vehicles. It turns out it's actually one of my paramedics here in Life Care that was running to the car as a patient. The driver is exiting the car, walking away and waving at the crowd. So yes, we're seeing less of these in those particular settings. Additionally, we're not seeing them as much in hockey because everyone knows to wear a helmet and a face mask. Same thing even for baseball. I mean, you know, there are still some of the professional baseball players that will not wear a helmet that has the jaw guard because that really protects even their zygoma, and we'll talk about that in a minute. But you know, of course, they want to turn away from that pitch as it's coming to them anyway. So you know, those things have truly helped a lot. But even before all of those things, like I said, I've been doing this since 1981, 82. And I just have not seen more than 4 or 5 of them in my entire career. But excellent questions. Is there anything else that anybody else wants to ask right now? So we're about to get into other facial trauma.
You guys can also unmute your mic briefly and ask your question. You don't necessarily have to type.
I'm not going to jump down anybody's throat.
Yeah, he's actually a big teddy bear.
So we'll go ahead and move on. So other facial trauma. So orbit, okay, these may be fractures due to direct or indirect forces, and the way that you need to think about that is that the orbit is like an ice cream cone, okay, not one of the, it's one of the cone-shaped ones. And so it truly is that shape. So you've got one injury that can hit the rim of that ice cream cone and break a piece of it off. Okay, that's a direct trauma. The other way that you can have this trauma is, imagine that you've got a blob of ice cream that's stuck in the top and you push it down too hard. The way that that ends up breaking things is, especially if you've got more ice cream in there, which we do in our face, it's going to actually push those things through that very thin wall of bone, okay? So those are the orbital blowout fractures, okay? And where those tend to blow out is that they tend to go into the maxillary sinus, so down below the eye. And so just real quick sort of thing, we're not going to expect you to pick up on these things, and even when they're there, this rarely happens, but you can get one of the muscles that helps to move the eye downwards. you can get that muscle entrapped down in that maxillary sinus. And in that case, when they try to move their eye up or down, it doesn't move right. And so they'll start talking about double vision and those sort of things. I see not a lot, but I've seen a lot of blowout fractures over the years, and I almost never see that muscle entrapment. So don't bank on that. If you've got swelling around the eye, just assume that there may be a blow or a fracture of some sort until they can get the proper imaging if there's been some sort of blunt trauma. Nasal fractures. The nose has very thin-walled bones, okay? They're very easy to break. They also generally are minor sort of things. They don't cause a lot of problems. You may have a thing called a septal hematoma. I'm not going to expect you to pick up on this, but it's the septum is a middle divider between each of the nares. And if you get blood that's in there, it needs to be found, because if we don't find it, it tends to eat through the septum, and then they end up with a hole there. So it's cosmetic sort of thing. But, you know, it's one of those things that if there's, and I don't think there's going to be a test item for you guys on this for emergency medicine. This is on every emergency medicine examination, that there could be a septal hematoma. I don't expect it for you guys, but once again, if you happen to look there and you see this thing that looks like a bruise on the inside of the nose, and you look at it with a pen light, you can look like such a hero when you come in and go, "Doc, I really think he's got a septal hematoma there on the left." Yeah, makes you look really good. If it's not there, hey, that's okay. That's not a big deal. I never worry about saying that something may be there and isn't. But, you know, at least that makes that ER doctor think about it. So that makes you look good. Once again, these nasal fractures are usually minor sort of things. They're hardly ever anything serious unless there's a lot of bleeding that's associated with them, okay? And so to that end, I've seen people that have come in that have had injuries to their nose, and their nose is sticking off to one side. And then after the swelling goes down is when the ear, nose, and throat people are going to want to see them. Their nose may be straight after the swelling goes down. I've seen some people that it's swollen all over and it looks straight, very symmetrical, and then they go and see the ENT after the swelling's gone down and it's cocked off to one side. You just never know. So other mid-phase. So zygoma. Zygoma is this bone that's right here. It forms part of the orbital rim. It also goes down and over what's called the masseter muscle, which is a muscle for chewing, and then it goes down into the face here as well. So the problem with that particular bone is it's very prominent. You get punched, you get hit with a baseball, you get hit with a hockey puck, you know, somebody hits you with a bat or something, it's very prominent. So it tends to break in what's called a tripod configuration. And because of those muscles that are attached to it, it ends up getting pulled down most of the time. And so it ends up with the sunken area here. This almost always requires that a plastic surgeon or a facial surgeon, ear, nose, and throat, one of those people goes in and they actually do the repair through the mouth and put some plates and screws into that. It's not a pleasant surgery to look at. So next we have oral trauma. So the problem with oral trauma is it tends to bleed a bunch. Now the good news is most of the time that bleeding can be pretty well controlled. So if they have a tooth that's knocked out and they're bleeding from that, you can frequently fold up a 4x4 or something similar and put in there and have the patient bite down on it. And that usually is enough to control the bleeding. If it's like a through and through wound to the cheek, you can actually take a 4x4 on each side and squeeze. Direct pressure generally controls these sort of things. Now, if you, and this is not going to be in anything that you're going to be tested on, okay? This is a little pearl for you to stick in the back of your mind if this happens to you. If you have somebody with either nasal trauma or oral trauma where they have this bleeding that you're really having some trouble stopping and your service carries TXA, tranexamic acid, that we're finding so many uses for that, especially on nosebleeds. where we're actually soaking some gauze and actually shoving that into the nose to help control that bleeding. Same thing with bleeding in the mouth. I've seen it used topically. I've also seen it where if they have bleeding from trauma that's kind of diffuse in their mouth, something abraded the area, they will actually do an updraft with this medication. So they put it into a nebulizer container and actually nebulize this and give it as an updraft, and it tends to control that bleeding. Once again, you're not going to see this on a test, okay? So don't sit there and make notes saying I'm going to see this on National Registry. You're not. But at the same time, if you're in a service where you have TXA and you have something like that, definitely call and talk to your medical director and see if that's something that you can do if it's not already in the protocols. So the ear, you know, my ears especially, they're out there, okay? So, you know, they can be lacerated. You can also end up with a hematoma. That's called the cauliflower ear. Now, the cauliflower ear is important because if that is not drained, just the same as the cartilage inside of the septum of the nose, that cartilage in the ear will end up being deformed as a result of that hematoma. So just because, you know, you saw it in Rocky and Rocky had this cauliflower ear, well, he still needed to get the thing drained or he's going to end up with some deformities as a result of that. Mandible. Okay, we already talked about this question one other time. Do your teeth line up when you close your mouth? Or when you close your mouth, do your teeth feel normal? It's a very, very important question anytime there's facial trauma, because it indicates a problem with either the maxilla or the mandible. And so just make that a routine part of your questions if somebody has facial trauma. Now, a lot of times with the mandible fractures, the way that you need to think about a lot of these fractures, especially mandible, forearm, lower leg, is these are a circle. And so have you ever tried to break a pretzel, but only in one place? It cannot be done. You have to break it in two unless you cut it. So unless somebody took an axe or something to the face, just anticipate that there's going to be another break in that circle that is the maxilla and the mandible, and you don't know where it is. A lot of times they'll complain of blood in their mouth and you'll actually see that it's an open fracture. So there's a lot of different things that this can present as, but the key question is, when you bite down, does it feel like your teeth are lining up right? Okay. TMJ location, temporomandibular joint location, dislocation. So this is right in front of the ear. If you put your finger there and open and close your mouth, you're going to feel the TMJ moving there. I have seen the same barber from when I was on active duty in the Air Force twice in the same day, where he yawned and dislocated both of his TMJs. And we ended up putting them in, told him, okay, don't yawn, you can't do that. He goes back over to the barber shop, and within an hour, he's doing it again, and he comes back over because he's dislocated again. So it can be very minor. My mom died last year. She was in her 80s. She was 85 at the time. And Mom, right before Thanksgiving, before she died, had an episode where she yawned and she dislocated her TMJs. But she had so many other medical problems that trying to give her something to sedate her or even for serious pain control was going to be dangerous to her. They ended up actually having to give her Botox in the muscles around her jaw in order to get it to reduce. And it was actually out for about a month before they could finally get her to the right person for that. So the trauma can be very minor in these sort of things, but the key is they cannot close their jaw completely. So, you know, it's something for you to kind of keep track of. So let's talk about how you're going to approach these things, okay? And I'm going to lump all of these injuries together, okay? First off, as we talked about just now, the injury can be through a variety of trauma. It can be very mild, such as yawning or laughing. It can be severe in the fact of a severe trauma car accident. It may result in many different injury patterns. It may be very mild and simple. They may be complex and life-threatening and anything in between there. So you need to kind of keep all of these things in mind. But the really important part of all this is that your main threat to the patient is not going to be these actual injuries. It's the other things that go along with it. Primarily, they can lose their airway. They may have an intracranial injury, or they may have another injury such as cervical or to their chest or something else that is really going to be a threat to their life. Oh, one of my granddaughters. So I can get it to advance. So our first considerations. Primary survey, okay? You have heard it over and over and over and over again. I heard it from 1981 all the way now to 2020. ABCs, ABCs. You know, I'll just tell you that the one thing about at every level that I've worked at, and we're not talking about just with EMS people, we're talking about with nurses, with other physicians, is how many times I have to remind them, go back and check a set of vitals. Go, you know, let me come and take a look at the patient. Let me do another assessment. Just simply walking in and talking to them. You got to do that over and over and over. So I even highlighted it again for you. The primary survey must be performed and then constantly reassessed. See, we even flew it in. A, B, C, D, and E the first time, and then continually reassess A, B, C, and D. Now, first off, go ahead and if somebody wants to unmute or if you want to answer this, A, B, C, D, E. Do you know all of those different components, what they all mean, and why they're so important?
Airway,
Not everyone at
breathing,
once.
circulation, disability, and I believe he is exposure.
Exactly. So you know how many times we have to remind people that exposure is you have got to completely undress the patient. You know, we don't see this anymore. Even when I was a resident, and this would have been in 1994, we were still seeing people coming in with mass trousers on. Not usually for shock, but for femur fractures. Do you know how many times we had to take the mass trousers off in order to take the pants off so that we could actually do a better assessment? It just happens. I get it. I started this stuff when I was 18 years old. It was actually about 2 weeks before I turned 18. And you know what? For me, thinking about cutting the clothes off of somebody, it just scared the crap out of me. But you're going to have to get over that. So just remember that you have got to completely undress the patient. You have got to log roll the patient. You've got to look everywhere at that patient. And then you got to do it again. Okay. So the ABCDE is a quick primary survey. Then you go and you actually feel every limb and those sort of things. Okay. So, and then I see Gabe brought up that it's XABCDE, and I like the exsanguinating hemorrhage as well. So, you know, I certainly appreciate you adding that in. Move the box a little bit. Since oral injuries may bleed, you really got to watch their airway. Once again, A is right at the start for a reason. So think about that airway. You've got to keep that in mind. And we'll even highlight it for you. Elevation of the upper body. Now, you know, we've come a long way since I had to learn how to use a short backboard to remove somebody from a car and then put them on a long backboard with the short backboard too. Times have changed a lot. And so just remember that some of these things may change as time goes on. But it always helps with somebody that may have a potential airway problem to elevate the upper body 30 to 60 degrees, and that way they can keep their own airway clear. They tend to swallow the blood rather than it just sitting there if they're bleeding in their mouth. And also It helps to raise that part of the body that has the head to keep the intracranial pressure as reasonable as possible. So, a few other considerations. Once again, bleeding. Oh, apparently I went too far. So, airway. Mandible fractures may actually make it easier for you to do laryngoscopy, because now this thing splits open right at the front or somewhere else to make it easier for you to see. But you may pay for it in having difficulty getting a mask seal, because now it just, when you try to clamp down on their mandible, it just moves out of the way in different places. Bleeding, if it's there, can hinder your views. One of the things that I teach my EMS guys, and I practice myself, I've told respiratory therapy everywhere I go that if it's good enough for my EMS guys to do these things and I make them do it, I'm going to do it as well. One of those things is that I always intubate with the head of the bed elevated to about 30 degrees. If there is any possible way to do that, it helps to remove all this weight here in the jaw. It pulls it downwards rather than it pushing it upwards. If somebody has a large chest, it drops that down, once again, rather than going upwards. It also makes it so that this is the area in the esophagus where they're least likely to have stuff coming up. So it just improves in so many ways. So if you can raise the head of the bed, do that. It helps with the bleeding so that it doesn't puddle in the back of the throat. It also helps with swelling. So especially if you have had this patient for several minutes, if you lay them down, you may start to get a lot of swelling in their oral cavity. Also, if a cervical spine injury is unlikely for whatever reason, please consider giving the patient, if they're bleeding in their mouth, a suction, a yanker, and say, okay, you can use this whenever you want. You know, suck that stuff out, keep it clean, and they'll do that. If they want to lean over and spit into a container to get the blood out, I don't have a problem with that as long as we know that their C-spine is okay. All right. No nasal airway devices. Once again, we talked about, especially on those Lefort 3s, that they tend to have CSF leaks. And so the last thing that you want is to have to explain why there's an endotracheal tube that you were trying to place nasally in this guy's cranial cavity. So nothing goes into the nose other than to control bleeding right at the opening. Just don't do it, okay? Definitely no nasopharyngeal airways. Oh, got to move the chat box. So other considerations. Eventually it'll come up, I'm sure. Bleeding. So you have a tremendous blood supply to your head and face. It's there for numerous reasons, but just keep in mind that anything to the head and face is gonna bleed a lot, okay? Nasal and intraoral wounds may be difficult to control, okay? Once again, we talked about that if you can apply direct pressure, that's great. You may consider on some of these to, apply something like TXA to help to control the bleeding. I wouldn't advise putting a quick clot into their nose, but those are some things that you can consider. Now, last one, okay, it's a joke. Don't put a tourniquet on their neck, even though there's some of the people that we want to do this to, okay? It's just poor form. You can't take that one back. But TXA is pretty darn close to controlling the bleeding just as well. I've seen it do really wonderful with some nasal bleeds in people that are taking some of the blood thinners that are not warfarin that can be reversed easily. So those are sort of things for us to think about. Now, at this point, we're at the end of the lecture part. I do have a couple of other slides. Let's get you guys, hit the questions that you have right now. Tell me what I need to let you know or what I should do different. I'm not against anybody saying, things like the XABCDE. Hey, you know what? I learn from this stuff all the time. We always need to be learning. So, Tell me what I can try to clear up for you now.
Hey, Doc, I have a quick question about more the oral trauma and the dental trauma. I've always wondered when we
Okay.
put these patients into the ED, and most EDs are dentists and oral surgeons actually being called, or like, how often do you actually see one of those guys show up in the ED?
Well, it is very dependent on the facility. I'll tell you that right now. When I was at John Peter Smith in Fort Worth, which is now a level 1 trauma center, at that time it was a level 2 trauma center, we saw those folks actually come in, but they also had a residency there. So they had residents that were in-house for both ENT and for oral surgery. So, that's a little bit different. Now, I'll tell you that just simply for a fractured tooth or an avulsion of a tooth, generally they're not coming in even for that, okay? What you are going to see is if you have somebody that has an open fracture that is going to have surgery, they probably are not going to come in at 2 in the morning, but you can admit those people and then they will take care of them, take them to the OR for whatever intervention that they need, whether that's an arch bar and then wiring their jaws shut, or if it's actually going in and putting plates and stuff in. Once again, the injury itself is not a life-threatening injury. These are things that generally can be taken care of on a less emergent basis, but you need to get them involved early. And so, one of the oral surgeons, actually he was a plastic surgeon, where I did my residency. He hated putting on arch bars for these folks that had the mandible fractures. I don't know if any of you guys are old enough to remember Clark bars, a candy bar called a Clark bar, but he would always sing that while he was putting these things on. He just hated putting them on. That was the only way that he could entertain himself while he was doing it. They're actually somewhat brutal surgeries. So, but they're not, to answer your question, the short answer is most of the time they're not coming in right then. Let's see. So Mark says almost 50% of lung volume is lost laying a patient supine. Absolutely. That, once again, is why those people that are short of breath need to be in a position of comfort. Okay. TXA, where can I learn more about this, about its use in the pre-hospital environment? I'll tell you that probably pre-hospital emergency medicine journal is where you're going to find a lot of that stuff. I encourage you, especially at a paramedic level, to read journals that are peer-reviewed journals. Pre-hospital emergency care is from the National Association of EMS Physicians. It is a peer-reviewed journal. It is very well done. I've known some of the people that are on the editorial board. They work very hard to produce really good literature. And what I would encourage you is you do need to learn a little bit of statistics. Do not read just the abstract. Do not just read the conclusions. You really need to read the whole thing. The other place that I would encourage you to start watching, and I have a clinical coordinator at Life Care that challenges me all the time because he listens to so many of these podcasts. There are several of them. I like what's called the SGEM or SGEM, the Skeptic's Guide to Emergency Medicine. And it is by a doctor in Canada who has a heart for rural medicine and also for pre-hospital medicine. I've talked to him on the phone a few times. He is a wonderful person, and they tell you everything about what they're doing about those journal articles. And so that is the way that you can look for some of those things. Rebel EM is actually by a doctor out of San Antonio at the UT Health Sciences Center there in San Antonio. Once again, excellent product. Salim Rabazi, I believe it is, who is, once again, a very good lecturer. I've talked to him many times in the past as well. And so, I would definitely recommend that you find some of these blogs that cover these topics. They're going to cover the pre-hospital stuff as well. I had hoped a few years ago and just didn't have the time or the I guess the smarts to set up a similar sort of thing to the SGym for pre-hospital. And so maybe that's something that with somebody's help here, we can get something like that off the ground at some point in the future. But reviewing these peer-reviewed articles that are applicable to our practice. So TXA, if you look it up, especially in pre-hospital emergency care, you're going to find several articles where they talk about use of TXA, primarily in trauma, but also some of these other applications too. How often do we have a jaw wired shut these days with the advances in emergency medicine? That hasn't changed. We still put cast on fractures, okay? So for the mandible fracture, those, the only way that you can actually fix those so that they are still, and especially given the tremendous forces of the masseter muscles when you chew, is that you have to do those with, they call them arch bars. So it's a metal bar that's all across the top and the lower teeth. And then they actually take a wire and they wire those shut. It just, that treatment has not changed, and I don't see that it will for a long, long time. And what are some ways to help remember the Lefort fractures? Well, just same, the way that I learned it was the same as any fort. When you build it, you start out with the lower level, so that's your foundation. So that's going to be just this part right here, okay? Then you're going to start to build up from the center, so then you get a pyramid. Then you start to build out and build the side walls. That's Lefort 3. That's the craniofacial dissociation. Excellent question, Deborah. Anything else?
I have a question for you, Dr. Phillips.
Okay.
So, you have a patient with a Lefort fracture, say a Lefort 3, you know, very severe Lefort fracture, and bleeding into the airway, these type of things. It takes a lot of force to create that sort of a fracture. So where does cervical spine restriction fit into the paradigm of pre-hospital care in this setting?
Well, first off, a lot of that is going to depend on your evaluation. But there's a lot of good evidence that would say that this particular maxim that I got from a neurosurgeon back in 1994, I don't remember the date, but I remember the rotation. It was the first day of my neurosurgery rotation, still holds true. And that is, we'd spent all day, finally the attending caught up with us, and I've been with the neurosurgery resident. So the neurosurgeon has a teaching file of x-rays. So he starts throwing x-rays up on the view box and is asking me what I think about them. And he was like, okay, so this is a cervical spine injury. Is it new or is it old? And I'm like, well, that one looks new. And then he throws another one up and he goes, how about for this one? I said, well, that one, the edges are smoothed off. I think that that's probably a remote injury. And he goes, you're right. He goes, I just want you to understand, and you need to take, and this time we called him peripheral brain. It was a little notebook that fit in our pocket. We didn't have cell phones and those things back at that time. He said, I need you to write this in your peripheral brain. You have got to remember this for the rest of your career. And so I opened up to a blank page and he said, broken bones hurt. Now, okay, what am I writing? He goes, broken bones hurt. And I said, I already know that. He goes, no, write it down. That's important. He's tapping on my book. Write that down. So I write down broken bones hurt. And he goes, you don't understand how many times I have patients that are transferred to me that have a cervical spine injury from a remote facility, and they were in a minor accident. And then when I take the collar off and I feel of their neck, it doesn't hurt. And they move their neck around and it's fine, but because they had a collar on, they got all these x-rays. So that still holds true even in these patients as well. I have never had somebody with a broken bone that has a distracting injury somewhere that if I push on that broken bone, that they don't say that it hurts. So that comes back to the whole nexus criteria, okay? I think that in these cases, given the scenario that you've got, where you have a Lefort 3, you have bleeding and, you know, high energy impact and stuff, Are you going to be wrong to put the patient into a cervical collar? Absolutely not. However, just remember that you do still have to keep an eye on their airway. And putting a patient into a cervical collar does not mean that they have to be on a backboard. So once again, we're trying to keep things as least restrictive as possible. And also, if you go back and you read, I want to say it was 2012, when NAEMSP and the American College of Surgeons Committee on Trauma came out with a joint position statement saying that we should not routinely be using backboards on patients. At that same time, you had several authors, including Brian Bledsoe, who came out and did some meta-analysis looking at some of these studies and said, okay, so where do we see, great example, I'll back up a little bit. He would put in his lectures a slide that had somebody being extricated from a vehicle if they were the driver during a collision. And he would say, okay, so your choices are these options. You can either put the patient into a cervical collar and have them get out on their own. You can have them just get out on their own without a collar. You can help the patient out of the vehicle. You can put them into a collar and help them out of the vehicle. You can put them into a collar and put them in a KED, Kendrick extrication device, or a short board, and then extricate them onto a full backboard. Which one moves the patient the least? And the correct answer has always been, in somebody that is awake, okay, somebody that is conscious, is that person putting them into a collar to remind them to hold their neck still and letting them do the work themselves. And the reason for that is anytime that you end up with a fracture, you end up with muscle spasm around that. Has anybody here seen a femur fracture, a real life femur fracture that's closed? Those tend to do this number if they're not under traction, just simply because of all the muscles pulling. So you get muscle spasm that helps to stabilize these sort of fractures so that they don't move anymore. So I think if I'm given that patient that you described, I'm going to say, okay, let's put them into a cervical collar, but I'm going to feel their neck. If they don't have any pain and they have bleeding, once again, airway comes before C-spine, even though airway and C-spine are in the same part of that mnemonic. I've got to maintain their airway, because if their airway is gone, they die. So, that's really kind of the bottom line. Everything has to be done on a case-by-case basis. It's nice to learn the principles, and the principle would still be to come back to that ABC. If you put the patient into a collar and their airway begins to become compromised, then you're going to have to maintain their airway. And I'm not saying take them out of the collar at that point, but you're going to have to do something to protect their airway and maintain their C-spine at the same time. Did that answer the question, or did that just muddy the water more?
I think it answered the question. And yeah. Okay. Jonathan Vasquez, you have not asked any questions. We need to make sure you're still here. Unmute your mic or something.
Pulse check.
Yeah, I'm here. I'm just don't really have any questions. I'm just enjoying y'all talking. But I'm here.
Awesome.
Okay.
Jason Holiday, how about you?
Yes, I am here. I'm in the same boat. I don't really have any questions. It's really good information, and I learned some things that I didn't really know about the Lefort fracture. So I appreciate it.
All right. I think that's everybody has participated so far, Doc.
Okay. Any other questions at this point? If not, I've got 2 sample questions for you, and we'll go over those all together. And so what I'm going to ask you to do on this is, when I put up the options for answers, I would like for people to put send a group chat message that just says what you believe that the answer is in that particular case. So the first one You arrive at a baseball field where a player has been struck in the face with a thrown pitch. There was no loss of consciousness. The patient can describe in detail every aspect of his injury. He denies numbness, tingling, loss of function. He denies neck pain. He is noted to have some dry blood at both nares and some bleeding from his mouth. You notice that his maxilla and nasal complex appear to move if you grasp his upper teeth, and he is spitting out blood from his mouth, and he maintains his own airway. Vital signs, his heart rate is 92, respirations are 20, pulse ox is 98% on room air, and his blood pressure is 142/80. So, how should this patient be transported? So, full spinal immobilization, lateral recumbent, or what's called the recovery position if you're in Europe, seated in a cervical collar on a cot, semi-recumbent in a cervical collar, or position of comfort. So make your choices. Yeah, that's a good one, Justin. I don't see an F as a possibility. That would be none of the above, right? I know, it's okay. I do that all the time. Okay, so actually E is the correct answer, okay? And would you, and I'll tell you right now that depending on when that question was written, you may end up with another option for this. But I will tell you that based on the current research, current literature, that with the patient with no loss of consciousness, he tells you everything, he can describe where he hurts, and he doesn't hurt in his neck, setting up in the position of comfort is going to be the best option for this patient. So excellent job. So next one, it's 21:30 hours, summer evening. You arrive at an ATV accident where there's a 42-year-old man who drove into a ditch that he didn't see. Anybody want to guess on whether or not the alcohol was involved? He states he was thrown over the front and he hit something on the ground. He denies any loss of consciousness, but he's been drinking a few beers. And he says that his jaw hurts, his mandible, and that his teeth aren't right. He's maintaining his own airway, and he is noted to frequently spit blood onto the ground and has an obvious open mandible fracture on the left at the first molar. So if you ask him to open his mouth, you can actually see blood there and you can see the teeth separate. Takes no medications, no allergies, vitals, heart rate 88, respirations 18, O2 saturation is 97% on room air, and his blood pressure is 128/62. So the same question. Cervical collar in position of comfort, cervical collar only, but supine position. So in other words, not on a backboard. Lateral recumbent or recovery position, long spine board with full immobilization, or setting up on a cot in position of comfort. So everyone make your choices. Proud of you, Justin. Last one, first one. Excellent. So everyone is saying the same thing, which is the correct answer in this case. Okay. With him having the beer on board, you can't really be sure that he's totally with it enough. And so according to the Nexus criteria, he does need to have a cervical collar on. So that's good. And I would let him set up however he's comfortable, especially with him bleeding in his mouth. So that's the last of the stuff that I've got. So do you guys have any questions for me? Okay, so, and the patient with possible mandible movement. Yes, Chris? Yeah, that's actually an excellent question, and it is possible. So that's why you do have to, no, that's okay. I type one finger at a time as well, so not a big deal. That's an excellent question, and I would say that yes, there is a possibility, and that's why you allow the patient to be setting up if he wants, however he's comfortable. And that way he can keep his own airway clear, but you do need to constantly reassess. So, you know, I've had these people that also, once you get them so that the collar is kind of closing their jaw, it actually helps their pain, so they do feel a little bit better. Now, of course, he had a little pre-anesthetic on board, so that's a different situation as well. But that's an excellent question. No, actually, the question from Deborah, does TXA work on a patient that's on warfarin? Actually, yes, it will. The first time that I used the stuff for a nosebleed was in somebody that was on, it wasn't Coumadin, but it still acts in the same manner, and that would be, I think it was on Xarelto. And it was a dementia patient from a nursing home who had been seen at our ER just the week before, transferred to a higher level of care because we didn't have ear, nose, and throat at that hospital. Got transferred because they thought that it was more of a posterior bleed. It wasn't. And then the patient came back to the nursing home, still on Xarelto, still shoving this thing up his nose, which causes most nosebleeds in America. And so, you know, we ended up having him again. And this time I packed his nose with the regular pack. Didn't work. Packed the other side, that didn't work. And so finally I said, you know, and it just so happened I'd read an article on it that day. And so we actually took a vial of the stuff and we put it on a Pledget and just shoved it in that side. Within a matter of a few minutes, it stopped. So, you know, is that normal? Probably not, but at the same time, you know, I've seen it now several times, including on a patient that was on Coumadin that had a nosebleed, and I'm trying to, it was an intubated patient that the nursing staff had tried to put an NG tube in and started her bleeding from her nose, and it was actually pretty copious, and it stopped it like that again. So it does work even in people that are on anticoagulants. So the question, Justin's question about does that match up with National Registry standards? First off, I will tell you that I am not an item writer for National Registry. I actually was invited to be an item writer last year about the same time, and just simply because of other conflicts, I was not able to be there. I know that National Registry has gone through a lot of machinations to improve their examinations, to be sure that they are more up to date, and to be more clear on these things. And I will tell you that if you're looking at this from what would be called a psychometric standpoint, and that's the science of measurement or the science of testing, they would tell you that all of the answers should be plausible, not necessarily right, but plausible. And I think that's what trips a lot of people up in some cases. However, the National Registry has gone through a lot of standards, and they actually have psychometricians that are on board with helping to screen these examinations. And I know that they have also hired some other staff to help with being sure that these exam items are more clear. So can I tell you that that's going to be on that examination? No, I can't. And can I guarantee
I can jump
that
in here if you like.
Sure.
I actually been on National Registry test writing committees and also deal with, and actually EMS testing uses the same standards. They work closely with National Registry to try to make sure that their examinations are in line with what National Registry has. And the problem is, Justin, that the textbooks are already outdated when they're published. And the textbooks, and the textbooks that we currently have for paramedic, like the textbook that you're using for your class right now, we're actually due, I think, to be republished this year. I'm sure coronavirus got in the way of that. And so they're already 8 to 10 years behind, and they haven't published the new ones, but they have to base their test questions on what is written and defensible from a legal standpoint. So unfortunately, no matter what they do and how many psychometricians they put on their boards, they can't write test questions that are not published in the textbooks that are being utilized by the programs for which they are testing. And so they do have a tendency to run a little behind on the newer standards of care, like, you were talking about nebulized TXA and these type of things. You're not going to see that more than likely on the National Registry as an option at this point. And in fact, there's even one question that brought up this particular lecture that's on the EMS testing test bank that is about LaForte fractures, and it wants to lead people down the path of the LaForte 3 with bleeding in the airway. Don't mention anything about the pain in the neck or no, but it's a distracting injury. So they're wanting to lead people to spinal restriction and then turning the board to the left side or to the side so that the blood in the airway can be maintained, which actually is not the current standards in any of the medical community discussions and even some of the newer medical books that are coming out. But the current paramedic texts still have not quite got there yet. Not even PHTLS, I believe, has gotten there yet.
Now, I would think that, I know that in a lot of cases, if it's in the medical literature and has been receiving somewhat wide acceptance, as long as it's not an off-label thing, okay, so we're mixing two different things, but if it's considered standard of care within the medical community, I would, at least in emergency medicine, I would think that that should still be something that the item writers, since a portion of them are physicians, that they should be at least closer to up to date on. But I agree, every textbook, when it's published, is 10 years behind. Being an item writer for the Emergency Medicine Certifying Board, I can tell you that we actually are encouraged to use journal references, provided that they are reputable journals and are considered widely accepted. So, and that, as far as I knew, when I was asked to be an item writer for National Registry, was one of the things that they were attempting as well. So,
And they may be, but they're walking
it,
a fine line.
And they're taking it very slow.
Yes,
so,
nothing moves quickly with the National Registry.
So I'm going to answer the question from Mark real quick, and then we'll jump back up. TXA for nosebleeds, because I brought up off-label indications, okay? That is an off-label indication. You're never going to see an off-label thing on something like your registry examinations, okay? It just will not happen, because since it's off-label, you may have a subgroup of medical directors that will never do things that are off-label. I don't fault them necessarily, but just understand that because of that, they cannot test on those sort of things like that, okay? What is the average recovery time for a LaForte fracture, and how often do these visits, our patients, require second visits? Well, first off, I would tell you that every bone that you break, regardless, is going to take 6 weeks to heal. Everything takes 6 weeks to heal. It's actually kind of amazing, because my first day on my trauma service, I had a patient that was in the ICU, had already been there for a couple of weeks, that she had been split from right her xiphoid process all the way down to her pubic symphysis. She tried to die on the operating table several times while they were trying to fix her liver and other stuff. And they gave her so much IV fluids that when they went to go and close her wound, they could not get the edges anywhere near together. And she had swollen so much that her wound was literally wide enough that a person could lay in her wound if they wanted to. It was at least 10 to 12 inches wide. And it had been packed, had some mesh in there, and it was just allowed to heal. 6 weeks later, 6 weeks after her accident, her wound had closed completely. It wasn't together. She had a defect that was probably a good 3 to 4 inches and had a huge scar there, but the wound itself had closed over. There was no open areas to her wound. So that hammered home the thing that we were taught in medical school, which is it's going to take 6 weeks for that small laceration on that kid's face to heal. It may be closed, but it's not completely healed for at least 6 weeks. Same thing with a bone. You break a bone, it takes 6 weeks for it to heal. It's just the way that it is. So as far as second visits, well, I don't know the answer to that one, because I don't take care of those people afterwards. They don't usually come back and see us. in the emergency department. I love ice on wounds. I'll just tell you right now, ice is great. Okay, it's a wonderful pain medicine. It works really quickly. It works right at the area where you apply it. So I think putting a cold pack onto somebody with a suspected facial fracture is a fantastic thing. Just don't try to pack their mouth with one because they're bleeding in their mouth. Okay, that becomes a tourniquet around their neck. So other than that, let's see. Okay. Yeah, and certainly, with community paramedicine, those are things where, and that's an excellent question, Chris. Thank you. As we develop this thing called community paramedicine, certainly we're going to start seeing that we may end up going to visit these people and to check on their wounds and those sort of things. I think that that's great. I don't think that we will ever see a day where a surgeon is going to say, oh, I did surgery on this person. They don't need to come back and see me anymore. We've got these community paramedics, and they'll come out and they'll take care of whatever. I don't think that we'll ever get to that day, but I think that it's not unreasonable for us to offer to those surgeons, and we're in the beginning phases of starting up a community paramedicine program here in Parker County. I think it's reasonable for us to say, listen, we can go and check on these people. If you would like somebody to go and take a look at their wound and stuff at day 3 after they get out of the hospital, we're happy to do that. I think that that's probably a fantastic thing for us. The problem that you're going to hear from everyone is, but how do we get paid? And I don't have the answer for that. But obviously, we want to do the right thing for people. And I would much rather say, you know what, we lost some money because we didn't, we weren't able to bill for something, but we did the right thing for people at the end of the day. That's obviously what I would rather err on the side of. But at the same time, that's probably why I'm not a multimillionaire. But, it's a great question. And I do believe that there is a place for us to be participants in that aftercare as well. Anything else?
All right, looks like we're about ready to tie this up. I think things have gotten quiet. So.
Now, no, I didn't explain this stuff that well.
Yes, you did. You did a great job, and we appreciate it very much, Dr. Phillips. I enjoyed your lecture. I'm sure everyone else here did as well. I will hopefully have this downloaded and posted in the MD Roundtable rooms here in a few days. Everybody, thanks for coming tonight, and I've posted your credit accordingly for your class.
And once again, if anybody has questions that come up later on, get in touch with me some way. If, contact Jane and just say, how can I get a hold of him? I don't mind if people have my cell phone number. It's probably on a bathroom wall somewhere anyway. So, feel free. I may not answer the phone when you call, but if you leave a message, I'll call you back or contact you somehow.
I'd probably hand out your email address first.
Okay. Well, both of them's fine. So
okay.
Not a problem at all.
All right, everybody. Good night. Thank you, Dr. Phillips.
Thank you. Good night.